Dr. Shivakumar Akulwad, next.
Myself, Dr. Shivakumar Balaji Akulwad. I am presenting effect of anatomical variations of osteomeatal complex on chronic rhinosinusitis. It's a prospective study. Chronic sinusitis is a group of disorder characterized by inflammation of mucosa of nose and paranasal sinuses at least for 12 consecutive weeks of duration. Osteomeatal complex, it is a final common pathway for drainage and ventilation of the frontal, maxillary and anterior ethmoid air cells. Anatomical variation at osteomeatal complex plays an important role in causation as well as in a treatment of chronic rhinosinusitis. Anatomical variations of uncinate process. It may be hypoplastic or laterally bent. In this case, infundibulum is a narrow space and which may difficult to enter. There may be a well-developed and medially rotated uncinate process that it resembles the anterior wall of bulla. If it is more medially rotated or medially bent, then it simulates like a middle turbinate. Different patterns of attachment of upper end of the uncinate process are there. Most common is attachment to the lamina papyracea. When it is attached to the lamina papyracea, in this case its upper end encloses within the blind recess, and that's called as recess terminalis. The commonest mode of drainage of the frontal sinus is medial to the uncinate process. Attaching to the when it is attached to the cribriform plate, that skull base, in this case frontal sinus drains into the infundibulum. Therefore diseases from the frontal sinus can spread to the maxillary sinus, and diseases from maxillary sinus can spread to the frontal sinus. If it is many times it attached to the that upper end of uncinate bends to medially to attach over the middle turbinate. It may be free lying in the middle meatus or it may be pneumatized. If it's pneumatized uncinate is there, it compromises the infundibulum. Variations of middle turbinate. Concabullosa. Concabullosa may compromise the ventilation and drainage of the secretions to produce chronic infection of the sinuses. There may be an intralamellar cell of Gunwald. Occasionally the superior meatus may pneumatize the vertical lamella of middle turbinate. Paradoxically curved middle turbinate may be there. Middle turbinate sinus can be there. If middle turbinate curls upon itself and produces concavity within it, that's called as middle turbinate sinus. Anterior head of the middle turbinate usually extends up to few millimeter in front of its anterior attachment to the lateral wall, but in some cases it may extend 1 or 1.5 centimeter further anterior. In such cases, it's difficult to negotiate the anterior portion of middle meatus. Variations of ethmoidal bulla. Extensively pneumatized bulla can be there, and that produces a large bulb. It abuts against the uncinate process anteriorly, then it compromises the infundibulum. If it abuts against the middle turbinate, that compromises the middle meatus. Variations of ethmoidal cell. Anterior and posterior ethmoidal cells may pneumatize surrounding bones like lacrimal bone, maxilla, frontal bone and sphenoid to produce various patterns of pneumatization, agar cell, halar cell or frontal cells. Agar cell may be 1 to 3 in numbers. Anterior ethmoid cells pneumatizes the lacrimal bone and frontonasal process of maxilla to produce the agar nasal cells. Prominent agar nasal cell tend to displace the anterior attachment of middle turbinate posterior superiorly. These cells, when well pneumatized, produce a distinct bulge on the lateral nasal wall and can compromise the drainage of frontal recess. Halar cell, the anterior ethmoidal cell may pneumatize the roof of sinus, and this migrated cell is called as halar cell, and it's usually seen in the floor of the orbit. It can be very often compromises the infundibulum. Frontal cells, anterior ethmoidal cells may migrate into the frontal recess area where they named as a frontal cells. There are 4 types of frontal cells. Type 1, that single cell above the agar. Type 2 is 2 or more cells above the agar. Type 3 is also called as frontal bulla, a cell which extend well into the frontal sinus and simulates as like a frontal sinus itself on endoscopy or during exploration. Type 4 is isolated lonar cell within the frontal sinus. Supraorbital cell. Pneumatization from suprabullar recess may extend laterally over the roof of orbit to form a supraorbital cell. This cell is seen on coronal scans above the ethmoidal bulla and posterior to the frontal sinus. Onody cells. Posterior ethmoidal cells may pneumatize the sphenoid bone posterior superiorly to give rise a cell which extends superolateral to the sphenoid sinus. Optic nerve and sometimes ICA, internal carotid artery, they are seen in close relation with lateral wall of these onody cells rather than sphenoid sinus. Our experience, we studied 57 patients which are diagnosed as having chronic rhinosinusitis, evaluated with the CT PNS, coronal and axial views. On CT, coronal view is the base section passing through the osteomeatal complex. Associated anatomical variations and in all the sinuses were noted. Exclusion criteria was patients with acute sinusitis, patients having a malignant disease, or who had previous surgery either open or endoscopic. Results and observation. Total 57 patients were there, 30 males and 27 females. Male-female ratio was 1.11. In our present study, most common anatomical variation was well-pneumatized agar-nasal cells. That was in 52 patients, approximately 91%. Abnormal uncinate that agar-nasal followed by abnormal uncinate process, that was in 43 patients, approx 75% patients. Our most common anatomical variation for uncinate was bilaterally laterally bent uncinate process. That was seen in 35 cases. That followed by Heller cell, then enlarged bulla ethmoidalis, bilateral concha bullosa, paradoxical middle turbinate, unilateral concha bullosa, and onody cells. That onody cell was seen in only one patient. Discussion. In the study of Dio et al., they studied 50 patients. Their most common anatomical variation was most prominent or well-pneumatized agar-nasal. That was in 40% of the patients, and followed by concha bullosa. In study by Tiwari et al., they studied 85 patients. Most common anatomical variation was concha bullosa, that is in 65 patients. Then followed by prominent bulla, then abnormal uncinate, then agar-nasal, Heller cell, and onody cells. Mundra et al. And Bolger et al., both their most common anatomical variation was prominent or well-pneumatized agar-nasal, followed by concha bullosa, Heller cell, and paradoxical middle turbinate. Present study correlate with the study conducted by Bogler et al. And Mundra et al., where agar-nasal cell is the most common anatomical variation in CRS patients. Present study concluded that agar-nasal was the most common anatomical variation, followed by abnormal uncinate and Heller cells. Conclusion. The result of the present study re-emphasized the concept that anatomical variation in osteomeatal complex region causes obstruction to the mucociliary clearance of anterior group of sinuses, and it is the key factor for causation of chronic sinusitis. Agar-nasal cell was the most common anatomical variation, followed by uncinate process variation. The CT scan is the gold standard investigation in all sinus diseases and gives detailed bony anatomy.
I request Dr. Vishwas Dange sir to hand over the certificate to Dr. Shivakumar. Next paper, Dr. Vandana Thorwade.